airway management. This is a very important aspect of your scope. You can, to a certain extent, manage your patient's airway. All right, guys, this is going to fall under your ABCs. Remember, when we were going through that checkoff sheet, airway, you're assessing if it's clear or not, right? You're going to place an adjunct if they need it, that breathing status. Depending on the presentation of your patient, you're going to give oxygen therapy. Right, so that's definitely, we're going to learn about the different ways you can do that today with this chapter. All right, guys, let's go back over airway. This is going to be a review. All right, we've already talked about this pretty extensively for human body. We went pretty deep into respiratory system during human body. Okay, we have an upper airway and a lower airway. What's part of my upper airway? Okay, so your nose, your mouth. Okay, your epiglottis, your esophagus really isn't part of your respiratory system. That leads down to your digestive system. Okay, so your epiglottis, who's your epiglottis? Nobody with my analogy.
So the epiglottis is actually.
It'll be the nose, the mouth, the jaw.
Give me the question.
He's Gandalf.
Oh, that's right. Thou shalt not pass.
Right.
I think of it as a check now. Sorry.
All right. So nasal passages. We've got our mouth. We've got our nasopharynx, our oropharynx. Kind of tunnels down into. Sorry. Kind of tunnels down into your pharynx. Your epiglottis is here, and then your larynx is here. Guys, what's contained in your larynx? Your vocal cords, okay? That protective cartilage, your Adam's apple, all of that is going to be right there in your larynx. So that's where we move through those vocal cords. Your vocal cords are your gateway into your trachea. They lead directly to your trachea, okay? That's where our lower airway starts. Okay, what's my trachea made up of? How does it stay upright? Cartilage rings.
So your C-spine.
Yeah, it's like pieced together. Yeah. All right, so my trachea is going to come to my little dividing, little bikini bottom looking thing called the rhina. And then it's going to branch off into my what? Okay, what bronchi?
Your main bronchi?
My main stem bronchi. All right, I've got my right stem bronchi and my left stem bronchi. Those are the bigger, the wider passageways, right? From those bronchi, they go into smaller bronchioles. All right, and those bronchioles are going to start to branch out into these little grape clusters called your alveoli. Your alveoli are surrounded by your capillary membranes. Your capillary membranes are very permeable, and this is where we onboard who and offload who. Okay, fairly good review. Right? Everybody good? It's all over that. All right. Again, who helps me breathe tremendously? Diaphragm. Guys, it sits like this at rest. When you breathe in, it contracts and it pulls down. It opens up your chest wall and it creates what? Negative pressure, a vacuum, right? So it's just kind of pulling in. That negative pressure is just kind of pulling in that outside air to allow it to get into our lungs and to fill up our lungs. All right. When we go back to rest for the diaphragm, it helps push all of the air that's in our lungs out. We talked about earlier, we've got that pleural lining on the outside of the lungs and the chest wall, suction cup connection, and that's how when our chest rises and expands, it pulls the lung along with it.
Okay. It pulls it, it doesn't slide.
Because that connection is still there, so it's like, hey, come with me. Okay, so this is kind of a cross section of, these are gonna be your nostrils right here bilaterally. This is gonna be the back of your mouth, leading to your vocal cords, leading to your trachea, okay? So, what do we notice here? Who's this guy? Your uvula, little dangly dude, the back of your mouth, right? We need to know where that is and what that is and what happens when we come in contact with that. What happens when we come in contact with the uvula? When the uvula is stimulated, you gag, okay? That stimulates your gag reflex. Very important to understand when it comes to placing one of your adjuncts, why someone may or may not be a candidate for it, a proper way that we're gonna place this adjunct. Okay, is everybody good with what the uvula is and what it does when it's stimulated?
Yep.
Okay. So a bigger picture of the mouth. So again, there's the uvula. Here's our tongue. Guys, what's our tongue? It's a muscle. Proportionate to its size, it's the strongest muscle in the body. Okay. What have we already talked about? If we have a patient who is unconscious, unresponsive, like really out of it, what happens to the control of all of your muscles globally? They go away, right? That's why we might see that urinary incontinence, that fecal incontinence. You got to remember your tongue is a muscle. It is included in that loss of control when we go unconscious, unresponsive. How can this be a problem? How does it obstruct your airway? Usually if we're laying supine. All right, if my patient's laying supine, they're unconscious, unresponsive, what's gonna happen to my tongue? Because normally when it's taut, like when it's tense, it rests right up against the back of my teeth. Correct?
Right.
But when it goes flaccid, which means there's no control, there's no muscle tone to it at all, if I'm lying supine, what's gonna happen to the position of my tongue?
It's gonna relax and fall back.
Guys, that wives' tale, they swallowed their tongue. That doesn't happen. Okay, what happens is the normal tense position relax and it slips back, especially if they're supine, to the back of that airway, and it can either totally or partially occlude, cut off my airway. All right, so the tongue is one of the biggest culprits when it comes to an airway obstruction in an unconscious, unresponsive patient. Everybody good with what's happening? It's just kind of relaxing and sliding back. You're not actually swallowing your tongue. All right, so what do we have at the top of our mouth? A palate. We've got a hard palate and a soft palate, right? We've got that maxilla bone, right? That creates that hard palate, but it's also lined with that soft tissue. Okay, so like the roof of your mouth. All right, that soft tissue is soft. It's not very durable. If we introduce a very hard substance to it, we can cause trauma. What happens when we cause trauma to soft tissue? It bleeds.
It also gets sore too.
So yeah, it doesn't feel good, but it bleeds. Is blood a fluid?
Yes.
Yes. If my patient's unconscious, unresponsive, and I cause trauma to that soft palate of their mouth, and I introduce fluid to their airway that they can't protect,
Oops.
what am I worried about? Aspirating, my patient aspirating, not having control of their airway, and that fluid, instead of going through their esophagus, going down their trachea, getting into their lungs. Okay. Again, you need to remember that anatomy and that concept when it comes to placing one of your adjuncts, because you can cause trauma and possibly cause aspiration if you don't do it correctly. So again, guys, we kind of already talked about this, the thyroid cartilage, where it comes to that prominence, that's gonna be the Adam's apple. It's much more prominent in males. We've got these little cartilage rings that help keep my trachea upright and open because, again, guys, if those support rings weren't there, what would happen to that trachea tube every time I breathed in from that negative pressure that was created?
It'll get crushed.
Collapse on itself. You have to have an open trachea to have any type of perfusion, any type of respiration, right? This cricothyroid membrane, this is where if you have any issue with part of your upper lower airway, if you will, like the upper aspect of your trachea, we can, what we call as a paramedic level, cric somebody. We can go in and make a surgical cut to that membrane and then place a tube directly into the trachea from that incision site. So ALS can manage airway better than you guys can. Always have them en route to all of your calls just in case. Okay.
How often does ALS need to correct somebody in the field? I can't imagine it's very common.
It's not super common. Typically, you're going to see it with burn patients, like inhalation injuries, where the top part of their is just completely burned and swollen shut, or like a crushed trachea, like from trauma. So, not super often. I've never done it. Everybody good with this anatomy and what happens here? Bronchioles to the alveoli, gas exchange, capillary membranes, all that fun stuff. Do I need to go over that again?
If you could just really quickly, because I'm still kind of getting it flipped around a little bit.
Okay. So we breathe in air through either our nostrils, our nasopharynx, or oropharynx. All right. It travels down to the larynx. It goes through those vocal cords, and it goes directly into our trachea. All right. So now we're in the lower airway. From the trachea, we're going to go right here. So see why I call it a bikini bottom? Just looks like a baby suit bikini, right? To the carina. And then from here, we're going to branch off into the big tubes that go to my right lung and my left lung, my bronchi, my main stem bronchi.
Right, the main stem bronchi.
Right? From these big, wider tubes, they get smaller and smaller and smaller, and those smaller tubes are called bronchioles.
Bronchioles. And then from the bronchioles is the pulmonary capillaries and the alveoli.
Yes. From the bronchioles, we get those little grape clusters, the alveoli. That's what are lined with the capillary membranes. That's where that gas exchange occurs in the pulmonary circuit.
Okay. And then the diaphragm helps breathe, helps breathing and creates negative pressure.
Correct.
In that process. Okay. Cool. All right. Thank you.
Awesome. All right, so guys, this is just kind of giving you a visual that when the diaphragm contracts, it creates that negative pressure. It allows the chest to expand and to rise. Guys, this is just an exaggerated visual. Your lungs do not fully inflate every time you breathe. Even if you wanted to fully inflate your lungs every time you breathe, it's physically impossible. Your brain has a defense mechanism because it understands that if they fully inflate, they're going to do what? Burst. Not good, right? Anybody know the reflex that is deep-seated within your body that does not allow your lungs, like on your own accord? Guys, if somebody shoved like a ventilator down your throat and like pushed outside pressure, yeah, they're going to, right? But if you just try to breathe as much as you can in by yourself, you can't do it. What's that reflex called?
Self-preservation.
No, it's whoever discovered it. I don't know if it's one person or if it's two people. Herring-Brewer reflex. The Herring-Brewer reflex physically prevents yourself intrinsically from filling your lungs to full capacity. So guys, here's a better illustration too, exactly what is contained in that thoracic cavity, right? I have my right lung, I have my left lung, but right there in the middle, I've got those major vessels, my vena cava and my aorta and my heart. So now you can see a better example. If I have a compromised lung over here and I have built up pressure, if it starts to creep over, these things will become affected. And that's called a what? A tension pneumothorax. Okay, everybody with me so far? So guys, that's the mediastinum, that's that area that I'm concerned about when it comes to a tension pneumo, right? The heart, the esophagus is there as well, those great vessels, the vena cava, the arteries. Everyone good? We talked about this in shock. Respiratory system and cardiovascular system work hand in hand. We cannot have one without the other for an extended period of time. All right, we might compensate if one's not working well for a little bit, but then we can't do it anymore. We're gonna tap out. We're not gonna perfuse. We will die. Mediastinum. That's just right here, this space, this middle space between each lung and the thoracic cavity is called the mediastinum, where the heart and the great vessels are located. All right, so guys, we should know these definitions already, but just review. Ventilation is the physical process of moving air in and out of the lungs. Respiration is that gas exchange at the alveoli level. And then oxygenation is taking that said gas exchange and distributing to the rest of the body like it should. Perfusion, right? All right, so again, guys, ventilation, we've already talked about this, okay? This is the more active process of breathing, right? We have to work a little harder to draw the air in. And when we exhale, we don't really have to work that hard, right? That diaphragm relaxes, it kind of pushes the pressure out kind of by itself. So usually, maybe with the exception of like a COPD patient, we're going to see the patient struggle more so with the ventilation aspect of breathing, not so much the exhalation, except with COPD. We'll talk about that week after. Exaggerated visual, guys, your lungs don't deflate every single time you exhale. Why not? What's that term? What stays in there? Residual volume. Guys, if every ounce of air left our lungs when we exhaled, what would happen? It would stick to itself. Okay, anybody remember what that term is? No, the actual, like the lungs sticking, the internal walls, particularly of the alveoli, collapsing in and sticking to themselves. I said it in the human body. Starts with an A.
Alvestichium?
Very strong guess, but no. Atelectasis is that term.
Oh, that was the word I had trouble pronouncing. Yeah, I went wrong.
Atelectasis. 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 There we go. All right, guys, what's tidal volume?
That's the amount of air that is moved in or out.
So in and out. right? The amount of air when I go, that's my tidal volume. What's the average tidal volume for a healthy adult patient? 500 cc's, half a liter. Do I care about that number in the field?
Nope.
No, what do I care about?
The
Chest
rate
rise.
and the quality.
Do I have adequate chest rise for my patient? If so, I don't care what that tidal volume number is. I know it's good. It's sufficient. Okay. Dead space, what's that? Okay.
The portion of air that doesn't participate in the gas exchange, like whatever doesn't reach the alveoli.
Yeah. If I breathe something in, guys, every molecule that I breathe in is not automatically going to make it all the way down to my alveoli in one inhalation. On the same token, when I exhale, all of that CO2 is not going to make it all the way from the alveoli out just yet. So if it's kind of stuck in like that purgatory, if you will, it's not really doing anything conducive to gas exchange. Let's say it's stuck like right there in my carina. Okay. That next breath, I'll get rid of it. It'll participate in that gas exchange, but it's just kind of hanging out. It's not really contributing. Guys, we're going to talk about COPD extensively in respiratory. Just for right now, know that they struggle more so with exhalation, and they have problems with their oxygen and their CO2 levels because of that. Okay. There's technically a term called oxygen toxicity when it comes to COPD patients. We're going to talk about that for respiratory. But when you guys see in your book right now, it might say that like high flow oxygen is contraindicated for a COPD patient because of oxygen toxicity. We'll get there. And that's not really applicable to us. We'll talk about why later, okay?
When you say oxygen toxicity, that's because you have too much or too little? We'll talk about that.
It's the whole thing.
It's the whole thing.
Yeah.
More complicated.
All right, better pictures as to what's happening for that gas exchange that happens in the capillary beds for the pulmonic system or circuit. Very good. More pictures. Same thing. Are we okay? Okay. All right, guys, this is really important to remember. This is a little time clock you need to be familiar with when it comes to effectively managing your ABCs, especially making sure your patient is breathing and has oxygen. Because guys, you will be astounded and you're probably going to catch yourself doing the same thing. Right now, your wheelhouse of interventions and treatment as a basic EMT are managing what? ABCs, right? There's very few drugs you can give. There's very few interventions you can do. So y'all are the ABC gurus, right? When you move on to AEMT and when you move on to paramedic, you get to do a bunch more cool stuff, right? Start IVs, put tubes down people's throats, give a lot of different medicines, drill in people's bones, okay? You would be surprised if you come on scene to a patient who's unconscious, unresponsive, blueberry face, and you take 2 seconds to realize this is an opioid overdose. All right. What's your main thought right now? What do you need to do first for that patient? Breathe for them, right? They're cyanotic. They're probably not breathing hardly at all. Let's breathe for the patient. But when you move on to be able to do different interventions, you'll see people get focused on, okay, this is an opioid overdose. Let me get the Narcan and totally neglect the fact that their patient's blue and not breathing, and focus on drugs and interventions before ABCs. Okay, keep this time clock in mind. When it comes to that, guys, up to 60 seconds, just 60 seconds, 1 minute without oxygen, your heart starts to get pissed off. You can start to see different types of dysrhythmias in just 60 seconds without oxygen. Okay. 4 minutes, our brain is pretty much salvageable. 4 to 6 minutes, guys, 5 minutes. Depends on your perspective. It's either an eternity or it's just a blip on the radar, right? Brain damage. Okay, 10 minutes, absolutely gonna have brain damage. More than 10 minutes without oxygen, permanent brain damage. You're not coming back from that in full capacity. All right, so guys, that is why ABCs over everything else. Okay, is that clear? Yes, sir.
That's with no oxygen.
Okay. Everybody good with that hypercarbic drive and that hypoxic drive we just talked about in shock? That's gonna come back in respiratory. That's a big part of oxygen toxicity for COPD patients. Guys, this is just talking about you've got to have that cardiovascular system and the respiratory system working hand in hand. All right, we can't pump out oxygen if my cardiovascular system is not working. All right, I can't pump out oxygen if my respiratory system is not working. All right, so there are different things that can affect your patient from being able to breathe on their own. Okay, we've got intrinsic and extrinsic factors. What do you think intrinsic means?
It's inherent.
It's what?
Inherent, it's already there.
Yeah, there's something going on inside of your own body that's causing this hindrance. Okay, so we just talked about infections, right? That messes with the cardiovascular component, but how might that also affect the respiratory component? Okay, so maybe if like carbon monoxide is not really an infection, but it can prevent that from happening. What's it? Huh? So maybe fluid that turns into, huh? Yeah, that's pneumonia, right? We get a little bit of fluid or something that's not supposed to be there in our lungs. It sits there, we can't get it out. We can't fight it off. It sits there, it gets festered. It festers and it becomes infected. And it turns into just nasty mucus sitting in your alveoli. If straight up fluid can prevent gas exchange from happening, what do you think thick, sticky, gross mucus does? It's not happening at all. Okay, so if we have an infection that's hanging out in our alveoli, it's blocking those permeable capillary membranes, we're not having gas exchange. Pneumonia is a very big one. Okay, allergic reactions, what's happening to my airway to prevent me from ventilating? Swollen shut. Okay, if I'm not having any air move in or out, I'm not having gas exchange. Talked about being unresponsive, that tongue that can flop back, cut off your airway. Again, if I'm not having air moving in or out, I'm not having gas exchange. Extrinsic, this is outside factors, not that's internal inside of your body. Trauma, we can have them here.
All kinds of bad things.
Oh, use your imagination. All right, give me something. Give me an example.
Punch you in the throat really hard and collapses your trachea.
Somebody punches you in the throat, compromises those cartilage rings, and now every time you breathe in, what happens to your trachea? No air movement, no gas exchange. right? If we have a puncture to your trachea or to your lungs, we're not getting adequate air in and out.
And
You guys
damage from
know
an
stuff.
airbag, the same thing.
Huh?
I was asking, is like trauma from a airbag, is that a factor as well? Like it's like something that could be external?
Yeah, if it hits you straight in the throat, for sure.
Or maxillofacial trauma is like you hit your face on the steering wheel.
Foreign body airway obstruction, what does this mean?
Like food?
That's on broccoli.
Tongue control.
Your epiglottis fails you, right? Doesn't flop over, doesn't protect the trachea. What you're eating or trying to swallow becomes lodged in the trachea. It doesn't go down the esophagus, it goes down the wrong pipe. And if it's large enough, if it gets down there and it gets nice and comfy, we can't cough it out, it gets stuck. No air movement, no gas exchange. Death. Food. Right? Objects, especially with who? Kids. Everything goes in their mouth.
Or their nose?
Right? Like my younger son, Wesley, we call him Wes. He like just red dirt. Great. Rocks. Soot from the fire pit. That looks tasty. Let's check it out. Okay, so yeah. So Legos, coins, any type of small toys, if it goes down the wrong tube, gets stuck. Really common in kids. Talk about that. We'll talk about that later. Talk about those in shock. What's my normal respiratory rate for an adult? 12 to 20 breaths per minute. All right, what do I want to know when I ask for rhythm? I want it to be what? Regular. I can predict the next time my patient's going to take a breath. It's a regular kind of cadence, a tempo. What do I want to know, or what do I want to hear when I hear quality or I ask about quality? Okay, yes, I want my lung sounds to be clear, but what else, what am I looking for? Chest drives. I want that chest drives to be adequate. Guys, if you're significantly outside of that range of 12 to 20, we need to try to fix it. All right, if you're at 10 and your patient is otherwise fine, I'm not really concerned about that. If you're at 22, your patient's otherwise fine, not really concerned about that. But if we jump into single digits or like high 20s, 30s, they're not effectively breathing on their own. We need to jump in and help. Okay. If you hear shallow, or you see shallow when it comes to quality, especially that chest rise, shallow is not good. They're not effectively breathing on their own. You need to breathe for them. Okay. Again, guys, we use muscles. What muscles do we use normally to breathe in a small capacity? Intercostal muscles, those are where? In between your ribs. Neck muscles a little bit. What? Pec muscles, pectoral muscles, and abdominal muscles. Very minutely, we use those to breathe normally. If we see excessive, exaggerated use of those muscles, what is that called? So yeah, it indicates labored breathing, but it's called something specific. Starts with an A. Accessory muscle use. That's what we call it. It means we're having difficulty breathing, labored breathing. The most common irregular pattern you're going to see is something called Shane-Stokes. Again, I don't know if it's one person. I don't know if it's two people. But whoever figured out and made this correlation, Shane-Stokes breathing pattern. This is a regular, irregular pattern, if you will. It's not normal, but you can probably predict what it's going to do next. So your patient will start out very deep, very rapid breathing. It'll eventually slow down. The rate will slow down. The chest rise will become more shallow, and then they'll stop altogether. They'll go apneic. Then they'll pick back up with the rapid, deep breathing. It'll slow down, it'll get shallow, and then they'll go apneic. And that's the same regular irregularity, if you will, of Shane-Stokes. Anybody know what this means? Most likely?
I would say it's not good.
No, it's not good.
Is it that,
Got a wire
video
across
we
the line.
watched with the swimmer?
No, that was agonal breathing. Kind of, sort of, but why? Brain bleed. We've got ICP, intracranial pressure, is going to cause Shane-Stokes breathing pattern. We'll get back to that in trauma. We'll get back to that in neurological emergencies, but just introduced to it. Kussmaul's respiration. This is another really big one. We're going to talk about this more so when we jump into the medical chapter. But how is Kussmaul's respirations for them? Deep and rapid. Just consistently very deep inhalation and a very rapid rate. We will see this almost every single time with a particular medical problem. And we'll need to use some critical thinking when it comes to that patient with that medical problem with this breathing. But we'll get there later. Hey, everybody with me? You're good? Lunch is soon. Okay. Totally getting tacos today. Pretty excited about it. All right. So guys, there are two different ways you can open the airway. If you were with me during lab group, I'm assuming that Brett and Clary also talked to you about the different ways. But a basic level skill that, again, a lot of people neglect to do, they just forget about it because they can do all this other cool stuff, is manually opening your patient's airway. Right? That means changing the position of your patient's mouth or their head to try to alleviate, typically, the tongue. So guys, here's a little better visual. If you're laying supine, typically the tip of your tongue, if you're sitting upright or have control of your muscles, is gonna rest right up here at your teeth. But if you're lying supine, that muscle becomes flaccid. It's gonna slide back and it's just gonna rest right there at the back of your airway. What do you think we're gonna hear if we have a partial airway obstruction, usually secondary to the tongue? Snoring. Okay. Huh?
Sleep apnea?
So if you hear in real life on a real patient that they appear to be unconscious, unresponsive, and they're snoring logs, that's an airway obstruction. You got to fix that immediately. Or if you're going through your assessment and you ask for rate, rhythm, and quality of breathing, and your proctor says, breathing at 6 times a minute, shallow respiratory rate, and you hear snoring. I'm sorry, it's shallow chest rise and you hear snoring. Bad day. Partially obstructed airway, you need to fix it. Okay? So yes, if you snore at night, I guarantee you mostly only snore when you lay flat on your back, when you sleep flat on your back. Ever heard of the term sleep apnea?
Yeah, my dad has it.
It can get so bad that your tongue obstructs your airway for so long, you quit breathing during your sleep because your tongue is blocking off that trachea. Okay. So, guys, this is just an MRI of someone who is conscious. They're sitting upright and they're talking. So I'm going to mute the music. It's really annoying music. But I want you just to see how much the tongue moves. There's a point where the dude who's getting the MRI swallows, and you can see like the mouth is totally occluded, that it presents in like a white color. All right, so just how big of a hindrance your tongue can be to your airway, like at all times. Yeah. Right above it. So guys, this is the tongue, right? This is the excessive movement while just talking. See right here, this is going to be your trachea, your esophagus, that's your spinal column. See, just talking, it comes and partially starts to occlude the back of the mouth.
Neat.
Wait until he swallows. He licked his lips, right? You see it can poke out. There. You see that?
That's crazy. Well, now I know why when I was 40 and herniated 2 discs in my neck, having an MRI, they yelled at me for swallowing.
Then that's it. That's it. Lick his lips. All right, see that? That's swallowing. So you partially occlude your airway temporarily when you swallow. All right, so guys, you can see if the patient's unconscious, unresponsive, how tongue can be a real big problem.
So when people sleep apnea, right? I think they're not supposed to breathe.
Uh-huh.
How does that?
So that's called, it's a modified CPAP machine, continuous positive airway pressure.
Right.
So what it does is it's like a little mask that they have to wear. They're coming
It's like
strides with the technology. It's not, sometimes it's not like full-blown mask anymore, but it's consistently blowing pressure to keep your tongue displaced and your trachea open.
Really interesting.
Who's you get a brace and what's brace and what's
Yeah, I am probably way too violent with my husband when he sleeps because he snores like a freaking freight train. And it's always when he's laying flat. So he will wake me up snoring and I'll like do the whole elbow thing and I'm like kicking. Like I guess he's a hard sleeper, but yeah. Like he's like, what? Like, roll over.
Dude, you're snoring.
And then he rolls on his side. And where does the tongue go? To the side of the mouth instead of the back of the mouth. And he stops snoring. Great. So guys, remember, a lot of things can cause an airway obstruction. Your tongue, any kind of fluid. All right. So excessive blood, emesis, vomit. All right. Mucus. Any type of liquid can cause an airway obstruction, especially if your patient is altered to the point where they can't protect their airway. Right? If their esophagus isn't really doing their job, flopping over, protecting that trachea, anything that's in their mouth or anything that comes out of their stomach can go down the wrong pipe, get down there, block those alveoli, bad day. Okay? All right, guys, so the head tilt chin lift is one way that you can manually open your patient's airway. And you'll see. All right. Why do you think it's called the head tilt chin lift?
Because you tilt their head and lift their chin.
All right. So guys, one reason that we might have that airway or that tongue obstructing the airway is if they're lying flat, right? Another reason is if their neck is kind of kinked off like this, right? So we could partially kind of bend that trachea. So what we're gonna do, take sides of your patient's head and you're just going to kind of lift it up like that. If the trachea is kinked, we're gonna open up that trachea, make it nice and flat, right? If that tongue's there, it might push it forward a little bit, okay? So literally, head tilt, chin lift. You might see it done like in this picture right here. You're kind of off to the side, you're holding the forehead and you're pushing the jaw up and pushing down on the forehead. Oh, you probably can't see any of that. So you can do it from the side,
It seems like it's easier the way you first do it.
or you can do it parallel to your patient. Guys, if you are controlling, if you are managing your patient's airway, where are you going to be? At the head of the patient. Okay, guys, it's not really effective to manage a patient's airway from the side. You are going to be managing your patient's airway from the head of the patient. So that's typically why you see it kind of looks like you're holding C-spine, right? The way you would hold C-spine, but you're just going to tilt the head back and push the jaw forward. Okay, it's really simple. Guys, don't like break your patient's neck. Okay, it's not a massive, like huge motion that you're gonna do, just a very simple, let's get that trachea in a better alignment. Let's try to displace that tongue. Okay. All right, so you noticed that when I did the head tilt chin lift, my patient's neck did what? It moved. All right. Can I do this on a patient who has a suspected spinal injury? Why? Make it a lot worse, right? So guys, this is why if you were with me, especially for this patient assessment, when it comes time to open the airway on an unconscious, unresponsive patient, have I done a head to toe yet? Am I assessing my airway before I do a head to toe assessment?
Yes.
Yes. So is it very possible that my patient has a spinal cord injury that I have not yet found? Yes. So guys, the preferred method to open an unconscious, unresponsive patient's airway is going to be what we call a jaw thrust. Okay. So typically whoever is holding C-spine are going to take your thumbs. There is a little divot. There's a couple ways you can do jaw thrust. There's a little divot right here where the mandible meets the rest of the head or the skull. It doesn't feel good, but you can try to do it on yourself. If you really push hard, you can kind of thrust the jaw forward.
Brett tried to demonstrate on me.
Yeah, it hurts.
Not comfortable.
That's a good way for a painful stimuli too, right? So you can do that. You can push it forward and it'll kind of displace that airway, pull the tongue along with it. Or, and guys, typically the person who's doing C-spine, if you're holding up here, just kind of creep your hands down just a little bit, have your thumbs in place, and then push forward. Or just simply still holding C-spine, have your thumbs on either side of the mouth, and then just physically open the airway. Okay, because again, I can do this, or I can do this without doing this to my patient's neck. So if they're unconscious, unresponsive, guys, unless you can 110% rule out any trauma, do a jaw thrust to open the airway. Okay.
Hey everyone, Kurt here. We're going to talk about the second part of the MARC algorithm, which is airway, and some simple airway maneuvers to open and maintain the airway in an unconscious cavity. All right, head tilt, chin lift. Take one hand, put it on the forehead, tuck the fingers up underneath the chin, tilt the head backwards, press down the chin, open the airway, do a quick visual inspection to make sure nothing is including the airway, Look down the chest for adequate rise and fall of the chest. Make sure you have breath against your cheek. Once you've assessed that it's an open airway and an unconscious casualty, go ahead and secure that airway with a nasopharyngeal airway. And if you can't stay with the casualty, roll them into the recovery position. We're talking about the jaw thrust. Jaw thrust, you want to come down, use your ring fingers, seat it under the curve of the mandible. Seat your other middle finger and index finger along the jaw line. You're going to press up and out with your thumbs on the chin. This will allow a visual inspection to make sure there's nothing occluding the airway. You're going to look, listen, and feel for breath against your face, and look down the chest to make sure there's adequate rise and fall.
Okay, pretty simple. Guys, another good way to do the jaw thrust maneuver, especially like heated, kind of really manhandling that jaw, hold C-spine with your legs. Right? You're with me, I showed you how to do that. But you can hold C-spine, put their head kind of in between your knees, hold C-spine, and then you can have that pull both hand effect. This is the same one. I was really excited about this MRI. It's like the third time I've put it in. So just look at the diameter and the position of the trachea as you're going through these simple motions. We're extending it, we're making it larger. See, just that simple manipulation, kicked off very thin, now it's opened up nice and wide. Okay? Everybody good with head tilt, chin lift, and jaw thrust? Yes, sir.
So is the head tilt chin lift supposed to also help the tongue slip back above the airway? Doesn't seem like it.
Yeah, so both of them are, because in some aspects we're kind of displacing that jaw and those connective tissue that holds the tongue to the jaw will be pushed forward, kind of pulling the tongue along with it. Suction, I don't have that here. All right, so what if you do open your airway and you see vomit, or you see blood, or you see sputum? I hate sputum. Uh-huh. Okay, I have to get rid of that liquid before I'm breathing for my patient. Because if I don't get rid of the liquid and I put that bag on my patient and I'm forcefully ventilating that patient, where's it going to go? Into their lungs. We don't want that. So you have limited scope of practice when it comes to suctioning a patient's airway. Okay. You will use, and guys, when we come back from lunch, I'll go through all of these skills, okay, including the suction. But you will use a rigid suction catheter, also called a Yonker. Yonker. Y-A-U-N-K-E-R. Rigid suction catheter to suction out a patient's airway as far as you can see. You can't take that suction catheter and shove it down their throat. Okay? You can do that later on in a controlled manner. But right now, you're only going to use that rigid suction catheter to suction out like the oropharynx area. Hopefully get rid of all of that liquid, then move on with placing an adjunct, then move on with breathing for your patient. Typically nowadays, they're all portable. You might see them on the trucks where they're mounted on the wall to charge, but you can take it off of that charging mount and you can bring it with you on scene. This is another piece of equipment you need to make sure you have before you go into service, and that it functions and that the battery's charged. Why am I telling you this?
Because it happened.
To me. I didn't check off the suction. I saw it on the wall. I didn't look for the green light to see it was charging. Guess what the first freaking call we got right out the gate was?
Patient with an airway problem?
Cardiac arrest. Guess what the patient had done? Puked everywhere. Guess who had to look like a freaking idiot? crossing their fingers, hoping fire would show up with a functioning suction unit. Yours truly. All right, guys, so again, I promise you though, if you screw up something one time, you'll never do it again. All right, the very first piece of equipment I checked from that shift forward every day was the suction unit. All right, so just make sure this is charged, you're ready to go. It's part of your equipment you check off before you go in service. We'll talk about that when we come back from lunch. All right, guys, you've got 2 basic airway adjuncts within your scope. Okay, I put one on every table. You might have to go pair up. I didn't, nobody usually sits over here, so I didn't get stuff. All right, so the first one we're gonna talk about is your OPA. This little guy. Somebody said it's like the question mark looking thing, or like the little hook. Okay, there's 3 different sizes on your table. Okay, what does this stand for? What does OPA stand for?
Oropharyngeal airway.
Oropharyngeal airway. Where do you think we're going to place this? In the oropharynx, in the mouth. All right. How does this thing work? So notice it's a pretty hard plastic, right? And it's got kind of these divots carved out on the side, and it's got different holes going through the divots. Okay. So in theory, ideally, we're going to place this in the patient's mouth with a proper way to do so, that we'll talk about after lunch. All right. To go have this curvature go behind the tongue, and ideally pull it forward just a little bit, because this part right here is going to rest right here on your patient's lips. So we're hopefully displacing the tongue, pulling it out of that airway a little bit. But even if we don't, even if we just get this behind the tongue, what have I now made with these kind of cutouts and these holes? A little tunnel, at least, for air to go around the tongue into the trachea, into the lungs. Okay. So this is an OPA, an oropharyngeal airway, or an oropharyngeal adjunct. You might see it both ways. It's placed in the oropharynx. There's a particular manner that we place it. Ideally, it goes behind the tongue, pulls it forward a little bit, and creates a little passageway for that air to get down to the lungs. Who do you think we use these on? So anybody. Right, they do make, I didn't bring any of them out here, they make pediatric ones that get like that small. Kind of depressing to look at, right? We can use them on pediatrics, we can use them on adults, but who do you think? I cannot use this on someone who has an intact gag reflex. Why? Guys, the way you place it will brush up against the uvula. Okay, if I stimulate that gag reflex, what could possibly happen? They could puke. If I'm having to place an adjunct, can they protect their own airway?
Nope.
What's going to happen to that vomit? In the lungs. Guys, we call that, especially if they aspirate something, which means it goes down the wrong pipe. They have it directed to the trachea versus the esophagus. All right, it can develop what we call aspiration pneumonia. All right, if that patient vomits and that vomit goes down into the trachea and it goes into the lungs and it sits there and it becomes infected and it becomes pneumonia, that's aspiration pneumonia. We can cause that. Okay, we don't want to do that. Now, how am I going to determine if a patient has a gag reflex? Ask them. Am I placing this on a conscious patient?
No.
No. Right? I mean, I can try on you and see how it goes. Okay. But guys, am I going to go up to my patient and just kind of like open up their mouth and be like, hey, is that gag reflex working back there? No, you're not. Okay. You will find out when you're trying to place the OPA if the patient has a gag reflex. If they gag while you're trying to place this, be like, okay, nope, let's move to our other option. All right. And your other option is the nasopharyngeal airway. These guys,
So why don't you start with NPAs?
we typically do.
So you don't have to worry about.
There's
the
one
other
major contraindication for NPAs, which we're gonna talk about. But usually, guys, this is our go-to, okay? This is a flexible plastic tube. There are, for adults, 3 different sizes. This particular one is a 36. This is the largest that we have. 34 and 32 are the other adult sizes. Okay, where do you think this goes?
Your nose.
Through the nose, okay? So again, yes, this is a little safer when it comes to not stimulating that gag reflex. All right, so this is how it works. We place it into the patient's nostril, and then we're just gonna bypass, kind of create a tunnel, if you will, to try to hopefully go behind that tongue to have that air move in and out. Okay. Now, look at this picture. Where does this tube pass through? Your sinus cavities, right? Because there's a bunch of itty bitty bones that make up your sinus cavity. There's a bunch of inner workings for the different parts of the interior of your skull that are connected with kind of a webbing, if you will. The major contraindication for an NPA is someone who has suspected or confirmed significant facial damage or head trauma. Why?
Because that's actually those broken parts.
Okay, so it's very possible that there's a hole created from that significant facial or head trauma that we could say, whoops, that's not the normal anatomy, and we're gonna introduce this tube into brain. Is that good?
No.
No. We also could further displace any of those teeny tiny broken bone shards into any type of brain matter. So yes, this is typically our go-to unless they have a significant facial or suspected like major head trauma. Then we're gonna go for an OPA. Okay?
So in that case, if they have gag reflex, you just suck it out and shove it in.
What?
Like if you can't see out their nose and they have gag reflex too.
Then you're just gonna hold the airway open and bag them like that. Yeah. Okay, we'll go over how to put the OPA and the MPA in after lunch. Is everybody good with what it is, what it stands for, what it does? Okay. All right, the recovery position, what is this?
So on the other side, so they can't aspirate if they vomit while they're unconscious.
Okay, yeah. All right, so just like I try to very violently make my husband roll onto his side to displace that tongue so he stops snoring, if I can confirm that the patient doesn't have a spinal cord injury and they're unconscious, unresponsive, or they're significantly altered and they're starting to have maybe blood coming from their airway, or they're maybe having, vomit or whatever it might be, and for whatever reason, I don't have my suction unit, right? I can place them in what we call the recovery position. Typically, it's going to be on the left side. We'll talk about that later, because if we roll on the left side, we won't have as many problems with blood pressure as we will the right side. Anybody want to take a stab at why? On your heart? What did you say? So your heart's on the left side. We want to roll them on the left side. Because if I roll them on their right side, it's possible I could drop their blood pressure. How?
There's going to be more weight on the vena cava.
Put more weight on the superior and inferior vena cava. They're more susceptible to collapse or kinking off. I can lower blood pressure on the right side. So typically we roll on the left side. Okay. So again, I can have gravity be my friend. Now, if they vomit or if that blood's trickling down their airway, it won't go to their trachea, it won't go to their lungs. If I roll them on their side, where is it going to go? Out the mouth. Did anybody watch Breaking Bad? Do you remember when Jesse Pinkman got hooked up with his girlfriend who was a heroin addict?
Yep. He
Right,
watched it.
so foreshadowing that happened like a couple episodes before what I'm about to talk about. She told her boyfriend, who had never done heroin before, hey, when you shoot up and you fall asleep and you pass out, try to pass out on your side. Because if you throw up, then you'll puke, it won't go through in your lungs, you'll be fine, it won't kill you. But then Walt got really pissed because Jesse was hanging out with her. He wasn't making the mess like he should. He didn't like the girlfriend. This is after Walt went way to the dark side. Remember, he goes over to the house. He's knocking. They're not answering. They're both laying in bed. They've shot up. They're high, and they're both asleep. And he walks in the bedroom, and he's like looking at both of them. And then what does she start to do? She starts to throw up. She's laying on her back. She fell off of her pillow or whatever was propping her up. And what does Walt do? Nothing. Instead of rolling her over in that recovery position so she wouldn't aspirate and choke and die, he lets her lay there on her back, and it kills her. Yeah. That's why we like to utilize the recovery position, so we don't aspirate, so we can still have air movement, so we can still have gas exchange, right? Again, guys, no spinal cord injuries are eligible for recovery position. Lay them like this, lay them on their side, so gravity can be your friend.
Can you transport patients into recovery position?
What pregnant women?
Left lateral recumbent. All right, guys, oxygen. Okay. Be careful when you're handling oxygen. We're going to talk about how to put an oxygen tank together, how to hook it up. All right, we're going to go over really quickly the ins and outs of the oxygen tank. Guys, they're very dangerous if you mishandle them. Okay. If you are in class, if you're in lab and you're working with an oxygen tank and you leave it sitting straight up, whether on a table or on the floor, and you walk away from it, I'm going to call you out and you owe me 5 push-ups. Why? Why do you have to get into the habit of laying your O2 tank down flat and not straight up?
No clue.
No clue. All right, guys, if that oxygen tank is full, it's very pressurized on the inside. All right, so the way that they work, you either assemble them yourself or they're kind of pre-made, but there's a little neck right here where you connect what's called a regulator that allows a proper amount of pressure to flow in and out of this oxygen tank. If this is sitting straight up and it falls down, it's possible that that regulator becomes sheared off. That seal is broken, right? And what is this thing going to become if it just has an open path for all of that pressurized oxygen?
A torpedo.
Literally projectile. Okay, so we're going to watch Mythbusters. They're going to show you why. I'm going to tell you to make sure you lay it down flat every single time. Now, guys, this is extremely dramatic, right? They're purposely trying to do this. It's a really big oxygen tank. It's going to inflict a lot more damage than our tanks can, but it's the same concept.
Facilities have been around for 100 years, and legends of their destructive potential have been around for 99. Finding a ruptured tank really burrows through a brick wall. To the next county. Here we go. Steering the regulator off the tank. And gun number 2. And 5, 4. Cross your fingers. 3, 2, 1. That's the sound.
Science, baby.
Oh, God. It was the Lars that did it.
At 40 miles per hour, the air tank turned the cinder block to cinders. It even put a fair dent in the wall 6 feet behind it.
It didn't go all the way through, but it went through this one and it was gone. It was working its way through that one.
I was ready to see this as not possible. I was totally expecting it not to actually work. Because it's one of those popular tales, everyone we talked to heard the story, but no one knew anybody that it happened to.
You know, this was an optimum situation for this tank. What this tank did is as good as it gets.
My favorite thing is this perfect roundness of the top of this hole. It also pushed the entire wall back. Although the cylinder was deliberately aimed, you couldn't ask for a more convincing result. So let's call this myth totally and spectacularly confirmed.
Okay, so again, guys, it's not gonna be that big of an oxygen tank that was optimum conditions, but it still can do the same thing. Because especially if you're on a chaotic scene, what if you're on scene for cardiac arrest and fire's on scene with you and family members there, it's a stressful situation to begin with, no matter what. All right, but if you've got a ton of people kind of work around each other, you know, kind of bumping into each other, you have your O2 tank standing upright and it falls down, it can cause some damage. Maybe to fire, maybe to you, your partner, your patient. All right, so just make sure you get in the habit of laying your oxygen tank flat. Because guys, the O2 tanks we carry about yay big, and we carry 4 of them. We used to have taller ones, but we had an incident and a lawsuit, and now we carry the smaller ones. Because guys, even these small ones, when they are completely full of air, they're heavy. They're like 10 pounds a piece. Okay, so yeah, lay your O2 tank flat. Guys, be mindful that you don't want oxygen around an open flame. You just don't. That was one of the, when I went through the burn unit, one of the patients from literally the neck down, 90% of their body surface area, 3rd-degree burns because they were smoking while they were using their home oxygen.
Are you kidding?
No, I ran that patient. I think I told you guys. She was sitting on the porch smoking, like chain smoking. This was the one, like the walls were like brown on the inside, and like she smoked just constantly like a chimney. And she had her oxygen in her nose, and the oxygen tank was on. I'm like, ma'am, you either turn the oxygen off or you put the cigarette out. I'm not coming on the porch. But I mean, it can happen. So just make sure there's no open flame around oxygen. When you are utilizing it, we'll talk about the flow meter when we go through the skill. We're gonna come back to this oxygen toxicity and COPD patients in respiratory, okay? Technically, your book is gonna tell you a contraindication for high flow oxygen for is patients who have COPD. Guys, I need everyone to hear very clearly, in an emergency setting, the amount of time that you're going to be with your patients. I don't care if they have COPD. I don't care about any of their medical history. In an emergency setting, if they need high flow oxygen, you never withhold it. If your patient is actively dying and they have a history of COPD, you can't say, "Oops, sorry, bud, I can't ventilate you. I can't give you any oxygen. Can't even give you a nasal cannula. Sorry." It's like the epi, guys. You're never ever going to withhold epi if they truly need it in an emergency setting. Okay. So if any of your patients, regardless of their history, need high flow oxygen, you never ever withhold it in our field. Everyone clear on that? That changes when you get to a hospital long-term treatment setting, but for us, you never withhold.
To get to the hospital.
Yes. Okay, we will get there in respiratory, but just right now, no, don't withhold it ever. I don't care if they have COPD. Okay? Okay. All right, guys, we'll go over the devices. And then we'll finish up a little bit when we come back from lunch, and we'll go over our skills. All right, so you got within your scope 3 different devices you can use to deliver oxygen. All right, the first one, Jay, can you go hop at another table so I can use your stuff? Because I forgot to get stuff in my phone. So again, guys, when we were talking about pulse ox, right, depending on what that number is, depending on that patient's presentation, depending on if I think that number is accurate, that number and that presentation of my patient is going to determine how aggressive I am with giving oxygen. Okay, so if I have a patient who's a little short of breath, they're working a little bit, they're not cyanotic, they're not blueberry face, they're a little bit pale, clammy. All right, and I've got a true oxygen reading, oxygen saturation, that's anywhere between a 90 and a 95%. Okay, I'm gonna use a nasal cannula. Because guys, what is ideal? What's the lowest number I can have for that oxygen saturation that I'm completely okay with? Yeah, 95%. They don't have to be 99%. If they're 95%, I'm not gonna give them oxygen. All right, that 95 to 100% is great. So if they need a little bump, like if they're around 90%, they just need a little bump to get to at least that 95%, I'm gonna use the nasal cannula. This is my least aggressive form of oxygen therapy. So if they need just a little bump to get to that 95 to 100% range, I'm gonna use this. Okay, how does this thing work?
You put it in their nostrils, and then you wrap the tubes around the ear to keep it from shifting.
Get yours out, show and tell, touch it, look at it. All right, so yeah, guys, if you notice, there's gonna be a long tube end, and it's gonna have like a little connector port. That's what's gonna go hook up to our oxygen tank. So this other end is gonna go in your patient's nostrils, nasal cannula. Guys, please notice, this is another pet peeve of mine. If you look at these prongs, if you will, so I'm trying to get to where you guys can see it. They have an angle to them, right? Guys, the way that your air passages curve to make it down to your lungs, do they curve up?
Yeah.
No, they curve downward. So make sure you find the prongs. That downward slope is how you need to place them in your nostrils. Do not place them pointing up. What's going to happen if you place them pointing up? Not going to get as much oxygen down there, not as much concentrated oxygen to the lungs. And what else? Yeah, if I'm just directly blowing air to the top part of my nose that's not going down to my lungs, I'm going to dry out those mucosal membranes in my nostrils. All right, so guys, make sure the downward angle is pointing down towards the lungs. It's not going up your nostrils. If you ever get confused, there's a little plastic, like a semicircle right here at the bottom. That's supposed to rest right here in this little septum, or this little divot in your lip right below your nose. Okay, I'm not putting this in my nose. I have no clue where it's been. But that's supposed to rest right there. It's not supposed to poke your patient in the nose. Okay. So guys, with this, again, this is patients who are not really having a ton of difficulty breathing, maybe a little shortness of breath. We're within that 90 to 94 range. Okay. I'm going to hook it up to my oxygen tank, and I'm going to tell my patient what? How am I going to put it on? Little tickle, right? Because guys, these don't feel good. Like brushing up against those nose hairs, it tickles. It's really uncomfortable feeling. Okay, so I usually go ahead and take the prongs out and like kind of poke them out, make them a little wider. Place them in your patient's nostrils. All right, and then we're going to take this tubing and tuck it around your patient's ears. Okay, obviously guys, these are in your patient's nostrils. Again, not putting them in mine. Okay, tuck them around the ears, and then there's a little kind of fastening strap. You can control the tightness of it. Push it up. Don't pinch your patient's chin, right? But push it up a little bit so it's nice and sturdy and snug, and it's not going to fall off of your patient's ears. Super cool, right? Super cute. Then we hook this up to the oxygen tank. And what do you think our flow rate is going to be? 1 to 6 what?
1 to 6 liters per minute.
1 to 6 liters per minute. Okay. So guys, remember on your drug cards where I was like, hey, just know the dose ranges, and we're going to talk about like the separate devices later. You need to go back and add this to your drug cards. Okay. Everybody good on nasal cannula. It's the least aggressive. They just need a little bump to get them up to that bare minimum 95 number. 1 to 6 liters per minute, anywhere within that range. It can be 1, 2, 3, 4, 5, or 6. Guys, typically if we're doing a nasal cannula, we're not going to do a full-blown 6 liters per minute. Why? What do I run the risk of? Still drying out mucosal membranes, okay? So just technically it's 1 to 6, but usually not ever like a full-blown 6. All right, liters per minute is your unit of measurement for oxygen.
Then you also reassessing pulse ox check.
Yeah, I want to make sure my patient's responding to my intervention, right? I'm going to reassess that pulse ox. I'm going to make sure that number is coming up and it gets to that 95 to that 100 range.
How much of a lifetime is there going to be between setting up the nasal cannula and pulse ox readings?
Usually
Like
a
5
minute
seconds
or no, it takes like usually a full 60 seconds. Because guys, the circulation of 1 drop of blood takes about 5 minutes to get from that superior vena cava to the lungs, to the heart, to go to the rest of the body to start all over again. That takes about 5 minutes. But we can start to see reflections in like 1 to 2. Okay. All right, our next aggressive, all right, we're stepping up in our aggressive treatment, our device, all right, is going to be called a non-rebreather. Dang it. All right, this is what it's going to look like. It's going to have a face mask on it, and it's going to have an oxygen reservoir bag down here at the bottom. And guys, these are going to be for patients who are working pretty good to breathe. Right? They're still going to be conscious. They're going to be working a little bit harder. We might probably going to have maybe that diaphoretic, that clammy, kind of sweaty appearance. Okay. We also might have a little bit of cyanosis starting around the mouth or in the fingernail beds. Okay. Patients in the tripod position, right? If it's significant that they are having a good bit of respiratory distress, I'm going to go for the non-rebreather. Okay. Typically, guys, now these are all approximate, guys. These are not like black and white, right? These are all going to be depending on your patient's presentation, right? So you will see the abbreviation NRB for non-rebreather, okay? Usually anywhere between 80% and 89%. We're going to give, if we have an accurate pulse ox reading, we're usually going to use a non-rebreather for oxygen delivery. What's your flow rate for this? 10 to 15 liters per minute. Guys, why is this called, well, okay, so again, here's the long oxygen tubing. This is what we hook up to the oxygen tank. It's gonna come fill this reservoir bag and the oxygen is gonna come through this face mask. Why is it called a non-rebreather? All of these are disposable, yes, one-time use. I don't even know if any of y'all have it. There should be on one of these little kind of, on the sides, if you notice on Zoom, there are little holes and they have little holes punched out to create kind of like a filter, if you will. On one of the sides, there should be a small little like plastic disc, little plastic circle that covers these holes on the side.
Oh, no, it's sealed up.
Mhm.
You seal it up, for sure, we both seal it up.
So guys, I want my patient breathing in what?
Yeah.
Oxygen. But I don't want my patient rebreathing in CO2, right? Because I'm creating, even though there's a little bit of perforation right here, there's a mask completely surrounding my patient's mouth. So when my patient breathes out, that air that's trapped in this mask is high in CO2. I don't want my patient to rebreathe that back in, right? So the way that that little floppy little plastic valve works is it acts as a one-way valve, right? When my patient breathes out, when they exhale, it's going to go out those holes, but that little plastic piece right there is going to prevent that CO2 from being drawn back into the mask and it going back into my patient's system. So I'm breathing only this oxygen that's coming from the reservoir bag. I'm not breathing in or rebreathing any of that CO2 that they just exhaled.
So that oxygen's actually stored in the bag, or something?
Yes. Okay, everybody go to this. All right, guys, your most aggressive step is going to be your BVM, your bag valve mask. Who am I going to use this on? Unconscious, unresponsive.
Patients who are not ventilating insufficient.
Patients who are not effectively breathing on their own. Whether it's too slow, whether it's way too fast, or whether it's really shallow. Right? If I have a significant number outside of a normal respiratory rate, if I have shallow chest rides, okay, maybe if I have unilateral chest rides, is that effective breathing? No. So if I need to help the patient breathe, this is what I'm going to use. Okay? Talk about how to use it later, after lunch. Okay. Okay. But again, guys, this one's actually tucked up nice and neat. Okay. There is long tube right here. Again, this is going to go hooked up to your oxygen tank. The oxygen is going to come through this tubing and it's going to hang out in here like that reservoir bag for the BV or the non-rebreather. There's a face mask that goes on your patient's face. We'll talk about that proper technique, but you're creating a seal from this face mask on your patient's face, and then you are effectively forcing positive pressure in the form of ventilation into your patient's airway, into your patient's lungs. Okay. Bag valve mask. Yeah. Guys, we're using this if my patient's bad off, right? So guys, anything that is less than 80%, I'm really gonna think about bagging that patient for sure. Okay, what's my flow rate for this? Minimum of 15 liters per minute. Guys, we consider the flow rate for a BVM high flow. Okay. we talk about these oxygen tanks, when we come back from lunch, that flow meter that regulates how many liters per minute is coming out of the oxygen tank, the highest that flow meter can go. Some of them are 15 liters per minute. Some of them are 25 liters per minute. I'm going to crank that puppy all the way up with BBM. Okay.
How many minutes does this oxygen bottle last?
Depends on the size. If I have one of the size that we carry on the truck at Grady going full force, probably 15, 20 minutes. Okay. Everyone good on the delivery devices? What they are and when we would use them. We're going to get to how after lunch. Okay. And pause. All right, everybody back? Everybody go? All right, guys, so we're just going to talk about a few more things in lecture, and then we're going to technically have lab time, free time. I will go over the skills with you if you want to stay and practice some. I am going to dip out of here a little earlier. I'm almost done with y'all's schedule. That's what I was doing during lunch. So I'm going to finish that up so I can get that sent out. But yeah, we'll have some free time for sure today. Okay. All right. Tracheostomies. What is this? Okay. So a hole, an opening, all right, stoma in the trachea. Okay. Guys, you will see this in patients who are not able to control typically their upper airway for whatever reason. Okay, it could be like a spinal cord injury, it could be some type of neurological condition, it could be a physical thing that they cannot maintain proper control of their upper airway. Why is that a problem?
Not breathing through or out their nose. So you can't replace it.
So what are the dangers if you can't control your upper airway? What are some risks that you run? Oxygen. Okay, so guys, we've talked about a contraindication for patients who cannot control their, a contraindication for any PO medication are patients who cannot control their own airway because we're afraid that they will aspirate. All right, so if the patients can't control their upper airway, then typically a tracheostomy is going to be placed, because if they are having difficulty swallowing in that, maybe their esophagus isn't working well, maybe they'll have that muscle control, and they're running the risk of aspirating every single time they swallow. Okay, a lot of times they will opt to place a tracheostomy, which means we're going to bypass that upper airway altogether. We're going to cut right here in this membrane, and we're going to place a tube directly into the trachea. So when we breathe, we're breathing from here. We're bypassing the upper airway. We're eliminating that aspiration risk. Okay, this is what it looks like. So literally, surgical hole placed here. There's a tube. There's a balloon that they inflate to kind of anchor it in place. And then that tube is placed directly in the trachea. It goes directly to the lungs. All right. How is it secured on the outside? Usually 2 ways.
It looks like it's larger than the hole, right?
Hmm?
It looks like you got like some sort of gasket or something that's cinched down on the outside of your skin.
So yeah, you can either have this little device right here on either side can either be stitched into the patient's skin, or they can have like what you see right here. It's a very soft, called a trach collar. It just Velcros onto itself. It loops onto the sides of the anchoring device, the external anchoring device, and it's just around the patient's neck.
So does that take the place of your robotics then, that ball that's down in there?
Not, I mean,
It
yes.
looked like it blocked it, that's why I was asking.
I mean,
It looked like it-
yes, but it doesn't have the,
Well, it's not gonna
constant
flap like
motion.
that.
Yeah.
It permanently blocks that space.
if that balloon is inflated, it does create a separation from that upper airway and the lower airway, yeah.
They have to be replaced.
Yes, usually, yeah.
Sorry, what's your question?
If they have to be replaced, because I know like some for like gastrointestinal, They have the little tube in the stomach.
They can get clogged, they can get ooey gooey. Yeah. All right. Guys, what are some considerations? What if I come on scene and I notice that a patient has a tracheostomy and they are not breathing?
Well, that valve masking didn't do any good.
How am I going to breathe for them? Why?
Well, sure, you gotta have some sort of adaptation and salt on it, right?
Okay, so normally if I use BVM, right, I'm breathing for my patient, I place it where?
Hop off that thing on the face, right?
Over the nose and the mouth, right? Because that's typically how most patients gather their air, their upper airway, and then it goes down to their lower airway with no problem, right? If I go up to a patient with a tracheostomy, a hole right here in the trachea, and I put this bag mouth, or this mask over their face, and I squeeze, I'm breathing into that patient's upper airway, where is that air gonna go? Right out the stoma. Okay, because they don't have control of their upper airway. They don't utilize their upper airway to breathe. All right, the passage going to their trachea, to their lower airway starts right here. So if you're having to bag a patient who's got a tracheostomy, you're gonna hear it called a trach, what we call it. They've got a trach. How do we do that? Do I take this and put it?
No, I would think that it comes off of your medication.
Okay, at least in the US, this is typically a universal, fits every single tracheostomy stoma. Okay, you'll take the face mask off. We're gonna bypass that upper airway. We're going to connect this hub directly to this little plastic piece on the outside. Okay. My phone. It's my brother. I'll call him back. Okay. So we are going to directly connect this BVM to the stoma of the patient, or to the outside attachment of the trach, and that's where we're going to breathe for them. Okay, because that is their bypass to their lower airway. If I use it up here, it's going to go right out the stoma. It's not going to get down there. Okay. How would I give oxygen? Let's say a patient has a tracheostomy and they're breathing an okay rate, they're working a little bit, they need some oxygen. Say I just need to give them a non-rebreather. How do I do that?
Just plug it in. Oh, I'm sorry. I missed.
Am I going to put it here?
No.
Why? Where's that oxygen going to go? Guys, I'm going to hook up the non-rebreather, same flow rate. I'm put directly over the stoma. A trick for that is you can get a pediatric sized non-rebreather. They're about half this size, and it fits a little bit better. But that's where I'm going to deliver oxygen, because that is their passageway to their lungs, not up here. Here. You got to remember that with patients with trachs, the upper airway, useless.
That feels pretty good like that.
I mean, it's not
I mean, it's
really,
not good.
but if you're bagging a patient with a trach, that's going to be a good seal. We're going to bag a patient there.
Can you put this around the neck as well? Or you just hold it tight?
Yeah, you can.
Tape it.
Okay.
When you're bagging a patient with a trach, do you have to ever worry about like pressure muscle or mouth and nose, like, or is it like sealed up? Or
Sometimes, not usually, if there's a problem with that balloon.
Yeah.
Like if it's kind of dislodged, then it would kind of escape both ways. But if that balloon's in place, then it should just have that one direction down to the lungs. Okay.
Which is why you gotta put this on and not attach this directly, because they're exhaling through that thing too, right?
Yeah, there's not a universal hub for like a non-rebreather to connect to the stoma like there is the BVM. All right. So here's an example. All right, here's the tracheostomy. Here's that little external hub. This is a non-rebreather. He's placing it over the trachea. Sorry, the tracheostomy for that option to actually get down to the lungs, not with the upper airway. Okay. So here's an actual surgical placement of tracheostomy.
If you're looking to tone up or burn belly fat, then listen in because tracheostomy. By Dr. Christopher Chang, a Bonder ENT consultant. Here is an image of what a tracheostomy looks like. First step in order to create a tracheostomy is to make an incision in the midline of the neck as shown here. The next step is to remove the underlying fat in order to expose the underlying soft tissues. Here is a close-up of what is actually happening. The device that is being used is called electrocautery, which basically cuts and stops bleeding simultaneously. Any blood vessels that are encountered are clamped as shown here and divided. The blood vessel is then tied off using a silk suture to prevent bleeding. Here the trachea is completely exposed and now is being cleaned up. Using a scalpel, the airway is now entered. After creating the initial opening using the scalpel, scissors are used to enlarge the opening into the airway. Here you can see bubbles of blood due to the air pressure built up in the airway. In order to ensure patency of the opening into the airway, the bottom aspect is sutured to the skin as shown here. In this video segment, you can see the endotracheal tube being withdrawn under direct visualization, followed by complete suctioning of the airway of all blood and secretions. A tracheostomy tube, like the one shown here, will now be inserted. Here is a side view of what we just accomplished with the tracheostomy tube placement. An inner cannula is now placed in order to attach the airway circuit. The tracheostomy tube is then sutured into place to prevent accidental removal.
So how long was that? How much time did that take?
I mean, that, once they get the patient under and everything starts rolling, that's probably like a 30, 40-minute thing.
Yeah, okay.
Yeah, not long at all. Okay,
So you as a paramedic, there are paramedics that have done that?
not that.
Okay.
That's like an actual
That's like an
surgical
advanced-
tracheostomy. We can do a
Emergency,
right,
okay.
where we just simply cut through that membrane and then shove a tube down there and then they fix it and make it look much better in the OR.
I was just watching, I'm like, there's no way you got that.
No. That's an operating room. That's done surgically. Okay?
Thank you.
Okay, does it make a little more sense now? Makes sense, we have to give oxygen or breathe for the patient at the stoma, right? We cannot utilize that upper airway. Okay.
Is the one that you guys or that we would use or anybody would use, is it the same as that or is it different because of the emergency situation?
So we actually, I need to bring one up here. It's called, what we would use in the field is called an endotracheal tube. It's not that small. They vary in size. It's about yay long because it's designed to go from the mouth through the vocal cords to the trachea. So we would just put a modified placement of the whole length tube. So we would place it would be hanging out the neck a little bit more, but we would use the actual tube that, yeah, pretty much. All right, guys, it doesn't talk about this until later, I think maybe in respiratory, but I want you to go ahead and get familiar. There's a mnemonic or an acronym, shocker, that you need to be aware of when it comes to patients with trachs. All right. Patients with tracheostomies often can experience respiratory distress because of a lot of different reasons, right? Guys, if anything happens to that little tube right there, that's their only passageway, right? So the acronym DOPE, D-O-P-E. This is the acronym that you need to start going through this list in your head if your patient has a tracheostomy, and it could lead us to the root of that cause of the respiratory distress. Right, so D is going to be displacement or dislodgement. Displacement or dislodgement. All right, what can happen to that balloon? The balloon's that tracheostomies anchor, right? If that balloon comes under pressure, if it comes deflated in any way, shape, or form, it can not serve as an anchor anymore, and that tracheostomy tube can just be kind of moving around on the inside. If that part of the tube, if that angled part of the tube gets pushed up against the wall of the trachea, it can kink off that airflow. It can become dislodged. It can become displaced. Okay. O, what do you think O is?
Obstruction.
Obstruction. O is obstruction. All right, obstructed with what?
Who knows what somebody would put down
No. No. Huh?
Us?
Sputum. Guys, this is my one thing. I don't do this. I can do everything else. I can do blood, guts, pee, puke, whatever. I don't do sputum. It grosses me out. When I think about like suctioning out a trach that's got sputum in it, it's disgusting. All right, so they're very prone a lot of times to developing maybe like an infection around the incision site or the surgical site, because they're also prone to a lot of what? What is this an opening for?
Everything.
Everything. Bacteria, right? Nasty stuff, if it's not cleaned and taken care of properly, can get inside that trach, go down into their lungs, and a lot of times they can develop pneumonia. Okay, guys, this is the passageway. If they do have that pus, that nasty, just mucusy stuff in their lungs from pneumonia, what's their body naturally going to try to do?
Cough it up.
Cough it up, expel it from the trachea. All right, where's the passageway for that nasty, gross stuff to go?
right there.
Right there through the tube.
Yeah, it's a small tube too, right?
Ugh, it's disgusting. All right, so when you move on to AEMT and paramedic, you move away. We talked about the suction in your scope is a rigid suction. All right, this is what you get to use in AEMT and paramedic. This is called a deep suction. All right, this is a flexible plastic catheter. You hook it up to the suction and you take this puppy and you thread it down somebody's tracheostomy stoma until you can't thread anymore. And then you get it out and it makes the most god awful noise and just nasty stuff comes out. Okay? Not a thing. I don't have a poker face when it comes to making a disgusted face when I have to suction out a trach.
They know it's disgusting.
Oh,
Very often. Guys, especially in like a nursing home setting or somebody who is just bed bound, a lot of problems start to happen. We're not very healthy when we're not moving around. All right. So yeah, especially a lot of those patients, if you've got a trach, this is probably the first thing we're going to do to see if we can resolve that respiratory distress, because they get gunked up very easily.
Wait, so what does the P actually stand for?
We haven't gotten there yet.
Oh.
So O is obstruction, and it's typically obstructed with mucus and sputum and god awful stuff. Okay, y'all can't take care of that within your scope. Again, get ALS en route. Hopefully they can come deep suction trach.
People, do they not try to keep that clean themselves, or you just?
If they can't care for themselves, they provide on somebody else, and if that person's not taking care of it.
So many do, but some don't, or can't.
The nursing homes can't do that. They're in a nursing home.
They can.
They're confident.
I didn't say it. All right, what's the P stand for? It's kind of a false advertisement with this P. Doesn't sound like a P. Huh? Pneumothorax. Ooh. Why are patients who have a trach more prone to developing a pneumothorax? No.
I have no idea.
What are we completely bypassing? The entire length of the
Upper respiratory.
upper airway. Right, guys, this is a beeline, straight shot directly to those main stem bronchi in the lungs. Okay, a lot of the time, if you have a tracheostomy, you're hooked up to a what? Ventilator. If those ventilator settings are too high, there's too much pressure going in, we're removing all of the length of that pipe and putting it directly to the lungs. They're more prone to rupture. The lungs are more prone to rupture because you have a direct beeline of pressure. They're a lot closer in proximity.
That's a lot of
Does that make sense to everybody?
So it's a have to, i.e. they have to be connected to a
Not a have to. Some people have trachs and they don't have to have a ventilator. They just kind of breathe on their own with the trach placed.
No, I'm sorry. Seeing the symptom of a pneumothorax is directly linked to being on a ventilator.
Most of the time, yes. All right, what's the E? Equipment failure.
Yeah.
These patients who are on a trach, who are hooked up to a ventilator, the ventilator can fail. Or in my case, with my call that I ran, just become unplugged. We responded to a nursing home. Patient was in respiratory distress. He was becoming cyanotic. Did have a trach in place. So of course, I'm like, yes, can't wait to suction that thing. Right? We get there and we go in. Of course, we start managing ABCs. We're bagged and hooked up to the stoma. And then we're looking around, we're talking to the nurses, and literally the ventilator had become unplugged. And it wasn't breathing for the patient like it normally should have, and that was the cause of the respiratory distress.
Why does that happen by accident?
I feel like there should be a more complicated bug.
Normally they have like a backup system, yes. I don't know what was going on, if there was like intentional stuff, I don't know. But the ventilator was unplugged. So make sure your equipment's turned on, the battery's charged, or it's plugged in, if the patient relies on that piece of equipment to breathe for them. Okay?
So that's more so focused like ventilators.
Yeah.
not-
All right, so dislodgement or displacement, obstruction, pneumothorax, and equipment failure. Can you guess your first pop quiz for this module? Email me and tell me what dope means.
Wait, what was that quiz again? Sorry.
Oh, Carl's like, wait. I'm actually listening now. What'd you say?
The quiz, coach.
Email me and tell me what dope means. And why you need to know what it means.
Because it's the quiz.
Exactly. All right, guys, humidification. Why might we give someone humidified oxygen? Okay, we don't want to dry out the mucosal membranes. Maybe they're on like a long-term oxygen treatment. They have to humidify the oxygen so the mucosal membranes don't dry out. Why else? Could it be treatment for anything? Okay, so maybe.
If you have a lot of like mucus buildup and have to displace that.
Really? Guys, two big things that you're going to give humidified oxygen for are going to be like upper airway issues, like epiglottitis. We'll talk about that when we get to respiratory. What other injury might you think could benefit from humidified oxygen? Huh? Maybe a burn or an inhalation injury, right? If they're involved in like a structure fire or any type of fire and they're breathing in anything that's really, really hot or that smoke, it can singe, it can irritate, it can mess up the lining of your upper airway. Humidified oxygen is great for that because what does it do? Makes it nice and moist, so maybe we can restore that natural kind of the moisture to those cells. But also, what else is it? Maybe. Typically, by the time it aerosolizes to get to the patient for it to breathe in, it's cooler in temperature. So the moist, cool aspect can try to help subside some of the swelling. Okay, guys, this is the only time within your scope you're going to handle what we call a nebulizer. Okay, remember what I said this is used for? You're going to see this used for on the trucks? Albuterol. Right? Those little plastic bullets that had that liquid, that albuterol in it. Okay, you'll see you pour the liquid in here. All right. You put this back on. You hook this up to oxygen. You put it on your patient. And how I showed you that kind of that mucosal atomizer device with the Narcan, it just kind of misted it. It nebulizes that oxygen and that liquid medication, and the patient breathes it in. You cannot give albuterol through a nebulizer in your scope. The only time you are going to use this to deliver any type of treatment in your scope is humidified oxygen. All right, how you'll do that is you'll do the same thing. You'll unscrew this. You'll get some either sterile water or saline that's been in a sterile container. You'll fill this thing up. You'll attach it, put it on your patient, hook it up to oxygen, and let it aerosolize. Okay, typically around, I usually set it on like 8 to 10 liters per minute if I'm doing humidified oxygen. Trick of the trade, you've got holes here. They're not kind of corrugated like the non-rebreather is. You can put tape over these holes so the patient inhales more of that humidified oxygen or more of, you know, in an AEMT's case, albuterol. It's not, less of it is escaping from the mask. They're inhaling most of it. Okay, this is the only time you're going to use a nebulizer to deliver any type of treatment at your scope is humidified oxygen.
Like a sterile water sink?
Not a sink, but we carry like jugs of sterile water. Usually make sure you got like 2 or 3 of those on the truck before you go in service. Everybody good? Cool. Talk about that. Okay. Let's talk about CPAP. At the registry level, the national level of your scope of practice, this is within your scope. At the state level, it is not within your scope. State of Georgia says, no, this is too dangerous. I don't want EMTs having this as their scope. So you can test, you have to know all of the ins and outs of CPAP. It's going to be on registry. It's going to be on your test in here, but you can't do it in Georgia. So guys, we already talked about this machine. What does CPAP stand for? Continuous positive airway pressure. All right, you might see modified versions of these machines for people who have sleep apnea, who constantly need that force pushing through their airway to displace their tongue so they don't stop breathing. Anybody ever had to use a CPAP machine like on themselves in real life? Okay. Because the medical device for this is a lot more intense than what you have at home, what you sleep with. Okay, what is it doing? What is this mask doing when I hook it up to the oxygen tank?
Forcing oxygen down the throat, basically.
It has a constant flow, guys. It is like if you're driving down 75 going highway speeds, you roll the window down and you stick your head out of the car. Okay, it'll take your breath away. Okay. This is great for patients who need it. Right? What do you think it does? Who do you think I would use this on? Not unconscious, unresponsive. They got to be able to move some air on their own for this thing to help them. So if you're unconscious, unresponsive, it's not that's a contraindication for CPAP.
Somebody who's so exhausted from trying to breathe themselves that they.
Okay, so maybe somebody who's breathing really, really, really fast. That's technically within our protocol to use this on them at Grady, but we really utilize this in a specific type of patient. Well, they're going to be hypoxic, but why are they hypoxic? I'm going to give you guys a second to think outside the box. We've already talked about this condition and one way it can present, and it's bad, and it's a type of obstructive shock.
Embolism?
Huh?
Is it some sort of embolism somewhere?
Not embolism.
It's obstructive pulmonary disease.
Get in there. Pulmonary edema. Guys, what does pulmonary edema mean? What's happening? Huh?
What's on in your lungs?
I've got fluid in my lungs, chilling out in my alveoli. Is that where I need to have fluid? No. Okay. Most of the time, these are CHFers, CHF patients who are having a left-sided heart failure, and they're having an episode that they've got significant pulmonary edema. How do you think this is going to help? Push what out? Yeah. Guys, this is a great tool. It forces that air into the lungs, down to the alveoli, and it's forceful enough that it will displace. It will push that fluid that's sitting in the alveoli out. Okay. Doesn't aerosolize it. It literally just displaces it.
Blood flow just moves it.
It does what we call third spacing. It just kind of pushes it out of the alveoli, and it just kind of goes, doesn't really have a home. It just kind of hangs out outside the alveoli, but it just disperses the fluid so we can open up those capillary membranes again, and we can have that gas exchange occur. Okay. Great for these left-sided heart patients. This is pulmonary edema. This is an amazing piece of equipment. Okay. How does it work? Let's talk about how it works, and let's talk about who can't have it because of how it works. Continuous positive pressure.
Say it's almost like a fan that just continuously blows air essentially.
Okay, yes.
Elderly patients can't have it.
Oh yeah, definitely can hook this up to a trach patient for sure.
COPD,
Yes.
COPD patients, because they have problems with exhaling.
To a certain extent, yeah, that's a contraindication. But the biggest contraindication is going to be someone who has one of the biggest contraindications. There's several kind of big ones. But why do you think a patient who has a systolic of less than 100 is not a candidate for CPAP? Clearly, I'm concerned that my CPAP can cause my blood pressure to decrease, right? If I'm,
Because you're pushing on her.
am I?
I mean, if you're pushing that air through there and it's on the lungs are going to push against it. I don't know what kind of pressure we're talking about pushing in.
Which gets the lungs with decreased cardiac output.
Not on the heart, not on the lungs. But where is some of that continuous positive pressure going to escape to? Thoracic cavity. Okay, where might some of that pressure that builds up start pushing? Your vena cava. How does that decrease blood pressure?
Because you don't have your turn line coming.
All right, guys, it drastically, remember, that pressure is gonna kink those vena cava, and it's drastically going to decrease what we call preload. That blood that's gotta get in those chambers to fill up, to be in there for that left ventricle to pump out. If that preload is not there, what is that left ventricle pumping out? Nothing. Okay, so CPAP increases intrathoracic pressure. That can kink the vena cava, that decreases preload, that decreases cardiac output. Decreases preload, which decreases cardiac output, which decreases blood pressure. I should make that John's quiz question. All right, CPAP creates intrathoracic pressure, which kinks the vena cava, decreases preload to the right side of the heart, decreases cardiac output, decreases blood pressure. Okay, so it can be detrimental to your patients. You can take your patient's blood pressure, even though we're getting that fluid out of the lungs. If we don't have a pressure, it's all for nothing, right? So that's a big contraindication for CPAP, is to have a systolic of less than 100. But yes, if you have a pneumothorax, you're definitely not going to put CPAP on your patient. Okay. If they're actively vomiting, you're not going to put CPAP on your patient. Why? Yeah, you're going to force that puke right down their trachea. Not good. They're unconscious, unresponsive, or significantly altered. No CPAP. Does everybody get how it works? How it's great for those patients that do have that pulmonary edema, but that intrathoracic pressure can cause it to have a negative effect on your patients? Okay.
So, I mean, is it sensitive enough that you could literally watch the blood pressure and then back something off to kind of get to a better steady state, or is it just something you do?
So when you get to A in paramedic, you can walk that very fine line of giving them fluid resuscitation while you're giving CPAP.
So you're offsetting.
Yes, but then if you give too much fluid, we're already having trouble with fluid backup in the lungs. So yeah, it's a slippery slope.
No, you said that, I was thinking of the last time I had water on the ground, I was using like a leaf blower, right?
Mhm.
It pushes that water out, so that's what you're saying, that oxygen's coming and it's pushing it. If you had a hose there with a bunch of water, then it ain't gonna work. right? I mean, you can't get it all out of the way as your point. If you're
I mean,
doing
no, you can.
it, then-
Oh, like if you're introducing the fluid
Yeah,
resuscitation,
yeah.
yeah, it just kind of, yeah.
How does it take for this to close out?
Stomas? They usually don't on their own. You usually have to kind of have it like sutured back together. I don't know. I imagine like around a month-ish. All right, guys, we're gonna talk about foreign body airway obstruction when we do CPR. That's universal choking sign. Okay, we'll talk about what we do when that is happening next week. Be mindful that dentures, guys, if they are not completely fixed to the gums, they can cause airway obstructions, okay? They can get displaced. Even if you are trying to bag your patients with a BVM, if they're not properly affixed to the patient's gums, they will cause you not to have a complete airtight seal with that mask. If you don't have an airtight seal with that mask on your patient's face, you're not going to get that air into their lungs. So if they're in there kind of like flopping around, all right, take them out and then bag your patient. Try to be mindful. These things are expensive. Okay, any type of like prosthetic teeth or dentures or anything like that, like thousands of dollars expensive. So we probably have bigger fish to fry if I'm having to bag my patient, but try to put them in a spot where they're not going to get either stolen or broken. Just
People who don't have teeth, they are expensive.
I imagine it's not gonna be, you can just go pawing off or whatever, so how do you cleanse stolen teeth?
there's a market for everything, I guess. Okay, questions, comments, concerns on the lecture?
This CPAP is like continuous pressure, is there any like discontinuous pressure or just breathing
So it is continuous pressure. It kind of picks up, it helps, it does push, like when the patient inhales, it encourages the flow there. It's not gonna like, blow open their mouth and then just like not allow them to exhale at any point.
So if that's not.
It's still going, but it's not as accepted by the patient. Like it's not as forceful.
Yeah.
I would say, I would put a CPAP on one of you guys, but no liability, so. Okay,
What is the equivalent to, like a self-contained
no, because that only gives if you try to take and it's just chilling if you're not inhaling. So there is still some constant force with the CPAP. It's the path of least resistance, right? If the patient's opening up their mouth, they're creating that negative pressure and that's where the air is going, it's gonna go right down. But if the patient's not breathing and not actively inhaling, it's still gonna be pressure, but it's just gonna be hanging out. I don't know.
No, I know there's forced air systems. I've never seen one in the hazmat application. But I have seen.
They're usually just the SCBAs.
And the portable ones, are they pretty high flowing?
They're not as intrusive as these because we're not trying to dispel or disperse fluid,
It's constant.
but it's just trying to keep an open path for air. Yeah. All right. Questions with you guys? Everybody good? Okay.